Mary Lou is a 60-year-old postmenopausal Caucasian female. She is at the office today to discuss recent diagnosis of osteoporosis and the medication she is taking. She was asymptomatic until 3 months ago when she experienced severe back pain while coughing. Plain film X-ray of the thoracic spine revealed a compression fracture at T4, and a subsequent DEXA scan was positive for osteoporosis. Past medical information is significant for a vertebral compression fracture 3 months ago. She has lost 1 inch in height over the past year. She has a history of DVT 10 years ago and hypercholesterolemia. She is lactose intolerant, and her current medications include a calcium supplement, a statin drug for her high cholesterol, Tylenol for pain, and she takes Boniva for osteoporosis, 150 milligrams by mouth once per month. Family history. Mary Lou's mother is 85 years of age, still alive, with a history of osteoporosis and breast cancer. Her father passed away at 45 years of age due to a myocardial infarction. She has no family history of diabetes, kidney failure, or liver failure. Social history. Mary Lou has been married for 35 years. She has no children and she retired this year. She has a history of smoking tobacco but quit 10 years ago. She denies alcohol and recreational drug use. She has a poor diet due to being lactose intolerant and a poor intake of fruits and vegetables. She has a sedentary lifestyle and she has a calcium supplement but dislikes taking it because the pills are too big. Her review of systems is mostly unremarkable. However, she does report localized mid-back pain rated 6 out of 10 on a 0 to 10 scale. Her appearance, she is a slight Caucasian female with increased thoracic kyphosis, a stooped posture, and in no apparent distress. Her vital signs are normal. Her height is 5 foot 2 inches. Weight is 112 pounds, which means her BMI is low at 20.5. She has no thyroid megaly. Neuro, cardio, and lung sounds are all normal, and she has no edema in her extremities. She does have some tenderness along the spinous processes in her thoracic spine, and it's more tender at T4. Her labs, her CBC and TSH are within normal limits. Her metabolic panel, her calcium is high at 7.5. Her calcium is low at 7.5. Normal is between 8.5 and 10. Her magnesium is normal at 1.7, and her phosphorus is a little high at 3.5. Her vitamin D levels are low. Normal is considered between 20 and 30. Insufficiency is between 12 and 20, and deficiency is below 12. So Mary Lou has an insufficient vitamin D level. Her ALT and AST is within normal limits, and her alkaline phosphatase is 200. So this is the ALP, and the bone ALP in osteoporosis can be 3 times above normal level. Normal level, depending on the lab, is somewhere between 20 and 150. So hers is a little high. However, she has been on the Boniva, which will lower these levels, so it's probably lower than it has been. Mary Lou's DEXA scan results, which measures her bone mineral density, came back with a T-score of negative 2.5 in the spine and a T-score of negative 2.1 in the hips. The DEXA scan is a low radiation X-ray capable of detecting small percentages of bone loss. And you are considered to have osteoporosis if you have a DEXA scan of negative 2.5 or lower. Osteoporosis is porous bones. Osteoporosis is a disease that occurs when density and quality of bone is reduced. Bone is being broken down faster than the body can build more. Risk factors for osteoporosis include being a woman, especially a postmenopausal woman. Before menopause, the estrogen protects your bones from being broken down faster than your body can build up more bone. Other risk factors include a family history, low calcium and vitamin D levels, some medications like steroids, some medical conditions, smoking, excessive alcohol intake, low levels of physical activity, and a thin body build or excessive weight can also be a risk factor for osteoporosis. Mary Lou's risk factors for osteoporosis include being female. She's postmenopausal, which increases her risk. She is white. She has a poor diet, so she has low intake of calcium and vitamin D. She has a history of smoking. She has a thin body build and low BMI, and she has a sedentary lifestyle. Osteoporosis diagnosis and treatment. Because bone loss is gradual and painless, there are usually no symptoms to indicate a person is developing osteoporosis. Often, the first symptom of osteoporosis is a fracture, and this is what happened with Mary Lou. Diagnosis is based on bone mineral density, which is measured with the DEXA scan. So the osteoporosis is defined as a T-score of less than or equal to negative 2.5. Severe osteoporosis is a T-score of less than or equal to negative 2.5 and the presence of at least one fragility fracture. Osteopenia, which is decreased bone density, but it's not bad enough to be called osteoporosis yet, is a T-score between negative 1.0 and negative 2.5. Normal bone density is negative 1.0 and higher. Screening with DEXA scans begins at age 65 for women and 70 for men unless other risk factors are present. So this did not catch Mary Lou's osteoporosis early, so she could start treatment earlier. One recommendation is to use the FRAX tool in the office to help identify patients that are at higher risk for osteoporosis. The FRAX tool is a questionnaire that can be used to assess 10-year risk and be used to guide screening and treatment options. The goal of treatment is to prevent fractures. Fall prevention is first-line therapy. Bisphosphonates are first-line pharmacologic therapy for postmenopausal women and for men. In postmenopausal women, estrogen is considered only for those at high risk, for whom non-estrogen medications are inappropriate. The osteoporosis medications include the bisphosphonates, which are first line and they inhibit bone resorption. Raloxifene and denosumab are second line, and they both inhibit bone resorption also. The denosumab also helps increase or build more bone. And calcitonin is considered third line. That helps inhibit bone resorption. And teriparatide inhibits bone resorption and should only be used after the above medications have not been tolerated or are contraindicated. Mary Lou has been diagnosed with osteoporosis and has been taking a bisphosphonate for the last 3 months. She had a friend who was on Boniva and she broke her leg and they told her it may have been caused by the Boniva. Is there another kind of medication? So bisphosphonates are considered first line for osteoporosis because they have the best risk versus benefit profile of all the other drugs used to treat osteoporosis. They should be discontinued after 5 years because at that point the risks outweigh the benefits. Now, the bisphosphonate drugs have some very rare, serious adverse side effects, and these include hypocalcemia, osteonecrosis of the jaw, severe musculoskeletal pain, GI distress, and rare atypical femur fractures. And this is usually associated with long-term use. In people who do not have very low bone density and who have never had a fragility fracture, the bisphosphonate drugs do not show any benefit, and that is from the numbers needed to treat website. That's their recommendation. Benefits in numbers needed to treat for the bisphosphonate drugs for fracture prevention in postmenopausal women with a prior fracture or with very low bone density is 1 in 20 were helped. So a vertebral fracture was prevented, and 1 in 100 were helped, meaning a hip fracture was prevented, and a very small number were harmed. Other medication options for Mary Lou, because she is worried about atypical femur fractures, include raloxifene or Evista and denosumab or Prolia. These are both second-line options. The Evista is a selective estrogen receptor modulator drug, a SERM drug. It does reduce risk of vertebral fracture and estrogen receptor positive breast cancer. However, there is a high risk for venous thrombosis and stroke, which makes this a poor choice for Mary Lou. The Prolia is another second-line option, and this is an injection every 6 months, and it is expensive. The Prolia is a monoclonal antibody drug used to treat osteoporosis, but it also has an increased risk of atypical fractures, and it's contraindicated in patients with hypocalcemia. So this may not be a very good option for Mary Lou. And a third line option is calcitonin in the form of calcitonin salmon. This comes in a nasal spray, a subcutaneous injection, or an intramuscular injection. With calcitonin, there may be a slight increased risk for cancer. In Europe, they don't use calcitonin because of this risk, and in the US, the FDA has discontinued calcitonin for this reason many years ago. However, when they examined the research, they found that there was no causal relationship between the calcitonin and the cancer risk. It is contraindicated in patients with uncorrected hypocalcemia, so this may not be the best choice for Mary Lou. And teriparatide, or Forteo, is recombinant human parathyroid hormone. It should be considered in younger and older postmenopausal women with severe osteoporosis who have experienced decreased bone mineral density while on the bisphosphonates. They may increase risk for osteosarcoma, hypotension, depression, and pneumonia. Because Mary Lou has not been on the bisphosphonates for very long, I wouldn't recommend this option yet. I would wait to see if we can get her bone mineral density a little bit better with the bisphosphonate drugs, or another option if she should choose. Recommendations for Mary Lou. Lifestyle recommendations. We want to decrease her fall risk. To decrease her fall risk, We are going to recommend installing handrails and grab bars in hallways, stairs, and bathrooms. We want her to use ample lighting, remove obstructions to walkways, use non-skid rugs, remove throw rugs, and place non-skid mats in the showers. We also want her to add low-impact exercises to her daily activities. These low-impact exercises should include balance exercises, and she should perform them 3 to 5 sessions per week for 45 to 60 minutes each time, and she should focus on proper posture during all exercises. I would recommend referring her to an exercise program to improve compliance with this recommendation. We want to reinforce that she should continue to not smoke, limit her alcohol intake, and we want her to increase foods that are high in calcium. In people who are not lactose intolerant, adding dairy products is a good way to do this. Mary Lou is lactose intolerant, so we're going to have her add orange juice and or almond milk that is fortified with calcium. She can also add oranges, broccoli, collard greens, kale, bok choy, sardines, roasted almonds, and sunflower seeds. Pharmacological recommendations. Mary Lou has decided to switch to Fosamax. She likes that they have less common side effects compared to the other bisphosphonate drugs. She does realize that all the bisphosphonate drugs have an increased risk of atypical femur fractures, but after we went through the options, she feels that the risks are worth the benefits and that this is the best option for her. Recommended dose is 70 milligrams by mouth once a week. We're going to, after 5 years, if her bone mineral density is stable, we're going to take a drug holiday. And then if the drug holiday is initiated, we're going to reassess need for treatment every 2 to 4 years. She should be taking a calcium supplement. She should be taking 1,200 milligrams daily, divided into two doses. So she's going to take 600 milligrams twice daily. And liquid and chewable forms are available for people who have a hard time swallowing the pills, and this is a good recommendation for Mary Lou. We're going to have her take a vitamin D supplement at 1,000 IUs of cholecalciferol daily. So in people whose vitamin D levels are between 12 and 20, treatment usually includes 800 to 1,000 international units of vitamin D3 by mouth daily, usually for a 3-month period. However, many individuals may need higher doses. So we're going to start with 1,000 IUs of vitamin D3, and then we're going to continue to monitor her serum 25-hydroxy vitamin D levels every 3 months. And our goal is to get those levels between 20 and 30. Fosamax. So some specific information about Fosamax. Mechanism of action. It slows bone resorption by inhibiting osteoclasts. Fosamax has a half-life of 10 years because it is stored in bone. Severe adverse reactions include abdominal pain, osteonecrosis of the jaw, musculoskeletal pain, atypical femur fractures, esophagitis, Stevenson-Johnson syndrome, uveitis, hypocalcemia, and anaphylaxis. Common reactions for Fosamax are musculoskeletal pain, GERD, constipation, diarrhea, nausea, flatulence, and photosensitivity. Safety monitoring. We want a baseline creatinine level. She is at risk. She has hypocalcemia now and is at risk for it. So we're going to monitor her calcium, magnesium, and phosphorus periodically. We can do that in 3 months when we check her vitamin D levels. The cost of Fosamax is 70 milligram tablets. There are 4 tablets in a pack, and you take 1 a week, so she's gonna spend about $163 per month. Interactions with Fosamax include NSAIDs and aspirin, which can both increase Fosamax toxicity. She should use Tylenol for pain instead, which she is doing. However, she is taking 1,500 milligrams per day, and her pain is not well managed. So I would recommend that she increase her dose, but just to stay below 3,000 milligrams per day. PPIs and angiogenesis inhibitors can also cause Fosamax toxicity, so those should be avoided. And mineral salts and antacids will decrease absorption, so those should be avoided as well. Mary Lou should be instructed to take her Fosamax in the morning with water. She should take it 30 minutes before her first drink, food, medication, or other supplements. She should avoid lying down for 30 minutes after taking the Fosamax to decrease symptoms of GERD. She will be instructed to not discontinue the calcium and the vitamin D supplements, as this may lead to hypocalcemia. She should follow up in 3 months for labs, and we're going to repeat the DEXA scan in 1 to 2 years to check on how effective the treatment is. And these are my references. Thank you for your attention.